And now I would like to introduce this evening's speaker. His name is Dr. Faraz Mohammed, and a lovely man from Chappaqua. And let me just read you some of his credentials. He's a Chappaqua resident, and he has an MD and MPH, was a Master's of Public Health. I think that is, and FAPA, which is Association of Psychiatrists in America, and is a core faculty member in the psychiatric residency program at St. Vincent's Hospital and an adjunct clinical assistant professor of psychiatry. He has extensive experience in outpatient psychiatry, excuse me, consultation liaison services, and neuromodulation, including TMS therapy for treatment-resistant depression and OCD. He also provides psychiatric consultation to educational institutions such as Southern Westchester and Putnam Northern Westchester BOCES. So please welcome Dr. Mohammed. Welcome.
All right. Thank you so much, John, for the, excuse me, for that wonderful introduction. And I want to thank you all for joining me today. So the topic I'm going to be talking about, like the webinar, is about, a newer treatment, or especially like for people who have mental health issues, especially depression and OCD, who don't want to take medications and therapy. I'm pretty sure that a lot of people know, those patients who don't want to be on medications or therapy. So I thought, talking about this newer treatment and educating, our community people about this newer treatment options, and I thought this, Chappaqua Library would be a very good platform. So, excuse me. So before I talk about the newer treatment modalities, I want to talk to you guys about, some of the mental health issues and how it has been impacting us in our day-to-day lives. So the agenda for the evening is that I'm going to be talking about the depression, what is treatment-resistant depression. I'm going to be talking about OCD, and like I was talking to you guys about the newer treatment, TMS, and I will talk to you guys more about what TMS is and what is it all about, and the risk and benefits, and where is it used. So before I start talking about the newer treatment modality, like I want to go over, all the mental health issues, as you all know, the mental health, issues are a major global crisis at this time. And before COVID, there were over 1 billion people suffering with depression. And as you know, especially for people who have been working in the field, that, the pandemic just worsened all, all the mental health issues. And and we know that this is gonna stay for a long time, or it might also, it might even get worse. So every day, our day-to-day lives, around 548,000 people, Americans actually, this data is from America, they call in sick for mental health issues, and it has a huge economic burden on the country. It costs around 200 million workdays per year. So before, and then I want to talk to you about, so what is depression and what is treatment-resistant depression? If somebody is not in the mental health field, they might have this question, like, what is depression? What are some of the symptoms of depression? So I just want to go over some of the symptomatology of depression. So, for example, as per the DSM-5 criteria, like the people or the patient who experiences changes in their sleep, appetite, energy, concentration, feeling hopeless, helpless, no, having difficulty getting out of the bed. They're not able to enjoy the stuff they used to, and crying for no reason. And if these episodes last more than 2 weeks, we consider that as a major depressive episode. And when it gets worse, it's, patients even have, they even report suicidal thoughts or self-harming behavior. And in the country, this is the data from 2023. I'm sure that this is, it has gone up now. If you look at the data, just this here. In 2023, there were around 8.5%, around 22 million people in the US. They had reported one major depressive episode in the previous year, and around 15 million people, they had severe impairment. And especially young adults, people who are from 18 to 25, they get hit harder, and in them the major depressive episode is around 17.5%. And if people here if they are working at a school, or if they're working with younger people, I'm sure that they must have seen this. So then what is treatment-resistant depression? So treatment-resistant depression is any kind of inadequate response to two or more than two antidepressant trials is considered as treatment-resistant depression, and this is as per FDA and EMA convention. And around 30% of the people who meet the criteria for depression, they meet the criteria for treatment-resistant depression. And like I said, 30% of the people, they have treatment-resistant depression, and they account for 47% of the total depression economic burden, and which is big, that is huge. And then I want to talk a little bit about OCD. I don't want to go into what OCD is like, what are the symptomatology. I just want to focus on a little bit of the impact of OCD. So in the US, the in the past year, the prevalence rate of OCD was 1.2%, but the overall lifetime prevalence is around 2.3%, which you might think is not that big. But again, if you think about diabetes or hypertension, they have prevalence rate of around 8 to 10%. But again, the OCD is definitely a little less, but again, it's quite significant. And you can see, women show higher, rates of OCD than men. Like I said, in another US estimate, 1 in 40 adults, around 2.5%, they develop OCD symptom during their lifetime. And most commonly, the first onset of OCD symptoms we see around, in teenagers, like around, in boys, we see around the age of puberty. And severe, when you look at this, the severity of impairment in OCD, around 50% of the patients who have OCD, they have serious impairment, and around 35% have moderate impairment, and around 15% have mild impairment. So I'm going to talk a little bit about this STAR-D study, which was done from 2000 to 2006. The purpose for going over this study, I want you guys to look at the efficacy of the medications that are being used in depression. So the STAR-D study, which basically stands for a sequence treatment alternative to relieve depression, was done from 2000 to 2006, and it was funded by National Institute of Mental Health, where they enrolled 3,671 patients at multiple centers all across the country. So what they did in this study was all the patients who meet the criteria for major depression, they were started on SSRI monotherapy, which SSRI is a class of antidepressant, which we commonly use in treatment of depression. So for the initial 3 months, they were put on this medication, and they looked at the remission rate. When you look at it, the remission rate was around 37%. So for example, if there are 100 patients, this is a hypothetical diagram I'm showing. So out of 100 people, only 37 people responded to the medication, and the rest 63 did not. So what they did in the study, after 3 months, for the next 3 months, they switched the medication to another medication in the same class or a different class, and they also augmented that with CBT therapy, which is cognitive behavioral therapy. And then they gave 3 months, and then they looked at the remission rate. So the remission rate was just 30.6%. So which is like, out of the 63 people, only 19 people responded. Then they give 3 more months, and then what they did was, during those 3 months, they switched to another class or augmented with another medication, or they switched the medication to a different antidepressant class. But During this time, the CBT was ongoing, and when they looked at the remission rate, it was just 13.7%. When you look at this number, it is just 6 people out of 44. Then after that, the fourth stage, which is for the next 3 months, then they switched to an MAOI, which is basically an older class of antidepressant, which we rarely use now, or to antidepressant combinations along with the things what they were doing in the step 3, and then they looked at the remission rate, and it was still 13%. So basically 38 out of those 38 people, only 5 people responded. So if you look at this diagram, overall this 33% people, they did not respond to even 4 medications. So only 2/3 people achieved remission, and these 33 people did not respond. Just to simplify this, as you see, with the first line of treatment, then 1 prior treatment failure, 2 prior treatment failure, 3 prior treatment failure, the likelihood of achieving remission goes down and down and down. So that was a major issue. That was a big problem, especially when we were considering antidepressants for treating depression. So then came, like, in year 2008, FDA approved a newer treatment for treatment-resistant depression, which is called transcranial magnetic stimulation. Basically, it's TMS. We call it TMS, or repetitive TMS. So transcranial magnetic stimulation was being done, from late 1990s, but it got FDA approval in 2008. So what it does, transcranial, magnetic stimulation basically refers to applying recurring TMS pulses to the specific area of the brain, and it has been studied as a potential treatment for several psychiatric and neurological disorders. I'm not going to go in detail into the neurological disorders, but there's a lot of studies that are being done in and looking into the neurological disorders. If somebody's interested, please Google or look at PubMed. There are a lot of studies that are being done. So what is transcranial magnetic stimulation? So transcranial magnetic stimulation is a non-invasive way of stimulating certain area of the brain tissue through the production of high or low voltage, low intensity magnetic fields, and is thought to modulate the cortical excitability. So the neuromodulatory effect of TMS depend on various factors, such as the frequency, the intensity, the duration, the number of session, the cortical target, and also the patient factors like age, disease state, medication trials, and also the symptoms. So this is how it works. So like I said, TMS stands for transcranial magnetic stimulation, and it is helpful in patients who have not responded to other forms of therapy. It is actually FDA approved for anybody 15 and above, but it is mostly used in adults. So how TMS works is by positioning a magnetic coil on the head, and it externally stimulates the certain area of the brain which is associated with your mood, like in this case, mostly depressive symptoms. So what the coil does, it emits a light stimulation, and it is aimed at a specific area of the brain, and it just feels like a mild tapping sensation on your head. But again, what it's doing is creating a magnetic field around that area, and it is stimulating that area of the brain that corresponds with your mood. What it does, it encourages the brain. So basically, as you know, brain is made up of like millions and billions of neurons which are talking to each other. So what the magnetic stimulation does, it makes them talk more, or it basically naturally increases the release, increase the release of the chemicals necessary to regulate your mood. So it increases the neuronal activity. That's what it does, and it increases the production of the chemicals that are hypo, which are like decreased in certain mental health issues. So this is how it looks like. So what it does, It is, like I said, it is a non-invasive procedure. It's a non-invasive and non-systemic treatment. For example, like medications, right? When you take medications, when you put something in your mouth, it has systemic side effects. When I say systemic, it can have multiple side effects. It can have weight gain, nausea, diarrhea, like etc., which I'm going to talk about later in the webinar. But it has systemic, medications have systemic side effect. This one does not have systemic side effect. It basically utilizes the MRI strength magnetic pulses to stimulate the area of the brain that is underactive. And this is how exactly it looks like. So there is a chair, it just looks like a dental chair, and there's a big machine on the side, and it basically creates the electric field, and it basically administers the not the electric, sorry, magnetic field through the coil. And so, like I said, it stimulates the area of the brain, and the patient is seated comfortably. And like you see here, there is a coil, which is basically a magnetic coil, which is positioned by the side of the scalp, and it generates rapidly changing magnetic pulses that induce an electric field. And it has a modulatory effect on the cortical excitability. Basically, it results in the depolarization of the underlying region of the brain, which is underactive. So studies have also shown that TMS is beneficial, have shown it's beneficial in treatment-resistant depression and also PTSD, especially by targeting the left dorsolateral prefrontal cortex. So later on in the webinar, I have some pictures like what I mean by dorsolateral prefrontal cortex and where exactly it is located in your brain. Apart from treatment-resistant depression, PTSD, it is also used for OCD and Tourette's. But again, in Tourette's and OCD, we target the different area of the brain, which is basically the orbitofrontal cortex, which I'm going to show you later, and also the supplementary motor area. So the area of the brain that is stimulated in certain disorder, like in depression, is the dorsolateral prefrontal cortex, and in OCD and Tourette's is the orbitofrontal cortex. So the area you stimulate is different. So let me tell you how exactly it is done. So whenever a patient comes for the treatment, what we do is there's something called initial mapping. So what we do is we map the area of the brain that corresponds with depression or anxiety or OCD during the first session. And once the mapping is done, we calculate the motor threshold. Basically, motor threshold is the intensity of the stimulation you need for activating that area of the brain. And that's something that is done during the first session, and during the subsequent treatment. Basically, you get the same amount of treatment, like the same intensity of treatment during the subsequent sessions. But again, I'll show you guys a little bit about the mapping and all later on. So TMS was, like I said, was being used since late 1990s, but it was first approved by FDA in 2008. It is perceived as a treatment modality alternative to ECT. But again, it is not at all like ECT. ECT, if you guys ever heard about electroconvulsive therapy, you guys might have heard about shock treatment. That's ECT. That's very different. So in ECT, the patient goes under anesthesia. They are basically sedated, and it has a lot of cognitive side effects. But TMS does not have any of those side effects, and you do not go under anesthesia. You're not sedated. Literally, the patient can drive to the clinic and get the treatment done and drive back to the school, work, or wherever they need to go. So again, when TMS was first approved in 2008, so it was cleared for treatment targeting the left dorsolateral prefrontal cortex. So these are the various conditions where TMS has potential benefit. But again, there are only 4 conditions that are FDA approved. So the 4 FDA approved conditions for TMS are: one is the treatment-resistant depression, the other one is obsessive compulsive disorder, smoking cessation, and migraine. So these are the only 4 conditions that are FDA approved, but TMS is used off-label for other other disorders as well, like PTSD, Tourette's, chronic pain, generalized anxiety, bipolar depression. And also there are a lot of studies that are being done looking at the benefits of TMS on movement disorders such as Parkinson's, functional tremors, focal epilepsy, cortical myoclonus, and spasticity. So let me tell you, like, if you guys know, like, a lot of people who have depression, they have underlying anxiety as well. So what I have seen in clinical practice, actually, people respond beautifully to anxiety, actually, on on TMS. You will literally, the area of the brain you stimulate is a little different for anxiety, but you will start noticing a difference in 2 weeks, where in depression it takes up to 4 weeks to see to start seeing some response. But again, anxiety, they respond beautifully, even though it's not FDA approved. It doesn't say it's FDA approved for anxiety. We use TMS all the time for anxiety as well. And like I said, the efficacy is very, it's very good when it comes to anxiety. So, like I said, I want to show you guys, where exactly is prefrontal cortex. So this is the cross section of our brain. And if you look at this area, this is our prefrontal cortex. So in depression, what happens is the prefrontal cortex, the volume goes down. So it's not just prefrontal cortex. If you look at the subgenual cingulate, which is this area, and also the ventral striatum, which is this area, they are hyporeactive. So basically the activity is down, even the volume is down, even at ventral striatum, this is down. So what we are doing by TMS is basically we are trying to improve the communication between these areas so that naturally it increases the production of the chemicals that can help with the depression. And so and again, this is the picture of the brain. Again, this is a little, if you can see, this is a little better picture. Basically, this is the dorsolateral prefrontal cortex. And when we start the treatment, so during the first session, this is what we do. We do the mapping and we look at this area of the brain that corresponds with the mood. And usually it is high frequency TMS. Depending upon the coil we use, it can vary between 10 or 18 hertz. And also depending upon the coil, it's around 1800 to 3000 pulses per session. And like I said, the stimulus is dosed to brain sensitivity, which is basically dosed based on the motor threshold, which is like basically you look at the intensity of the treatment you need during the treatment. So the standard protocol is that you need 30 treatment session, which is like around 5 days per week. But again, if you look at the duration, it's just 15 to 20 minutes, but to be precise, it's for depression, it is 19 minutes. And if you're trying to treat anxiety, there's additional 8 minutes of treatment you get. But again, like I said, patients respond very well. Like the people who have anxiety, they respond beautifully. But again, and sometimes they need additional sex tapering treatment. Sometimes it doesn't have to be 5 days per week. Sometimes it can be, 3 to 4 based on, if based on their availability. It's just gonna lengthen the course though. But again, the first, but you will need at least 20 sessions to see a difference. But again, with anxiety, you will see a difference like in 10 sessions. So what is the advantage of TMS? Like I said before, this is very natural. What TMS does is it creates an electromagnetic pulse and it stimulates the brain cells and increases the natural production of chemicals that regulate your mood. And this is a medication-free approach. A lot of people, a lot of patients, they don't want to be on medications. They don't want to be in therapy, maybe because they're busy or they don't want to open up in therapy. It can be multiple reasons, or sometimes they are experiencing, some side effects to the medications. So, this is a medication-free approach. And this procedure, this treatment does not require hospitalization. For example, ECT, you need to be in the hospital, you need to go under General anesthesia, you are basically sedated and they do the shock treatment. But again, this is totally non-invasive and treatment, and you don't have to go under any anesthesia. You don't have to go, and there are no cognitive side effects and no side effects of anesthesia. So this is basically like totally non-systemic and very, it's a pretty gentle process, and it has very minimal side effects, and it's a short-term program. Like patient usually see difference, anytime after 20 sessions. Like I said, in anxiety, you would see a difference sooner. So like I said, with the medications, it has a lot of systemic side effects. For example, like these are some of the side effects like weight gain, constipation, nausea, diarrhea, sleep changes, sexual side effects, fatigue, headache, tremors, and when you stop medications, then you start having treatment withdrawal symptoms and sometimes brain fog. So all these systemic side effects that come from medication, we don't see in TMS. But again, is TMS like risk-free? It doesn't have any side effects. That's not true. It has some side effects, but they're very minimal. So it is considered as a minimal risk procedure. So like in clinical practice, the most common side effect we see is a mild headache, like 10 to 15% of the time. But these patients respond to Tylenol right away. And after a week of treatment, you won't even have those headaches. Um, Sometimes since the coil is by the side of your scalp, there might be some mild scalp discomfort, but again, it's not that bad. Very, very rare. Like excuse me, 1 in 60,000 sessions, there's a risk of seizure, and so basically the incidence rate is less than 0.03%. So there is some risk of seizure, but it's very, very low. So these are the most common actually side effect of the treatment. And like you see, there are no systemic side effects, no cognitive side effects like the medications or the ECT. So, but again, you might say that, okay, this is something, it has minimal side effects. Why this is not being done in all the patients, right? So, but again, it depends, right? So for various reasons, there are very few psychiatrists who does transcranial magnetic stimulation anywhere in the country. And also for reasons like, the patients don't meet the criteria for treatment-resistant depression, or their insurance is not covering, or the psychiatrists are not trained in doing TMS. So there can be multiple reasons. So, but again, this is being done since late 1990s, and it has been FDA approved for almost 17 years now. So who cannot have TMS? Like, I said, I spoke briefly about, who can have TMS. I mean, I'm going to go over it again, but who cannot have TMS? So the absolute contraindication to TMS, if there is a magnetic metal anywhere within 30 centimeters of the coil in your head, then it's an absolute contraindication. That's actually a only absolute contraindication to TMS. Most of the dental work, like the braces and all, they're okay. Uh, the second session, even though this is absolute, I would say this is relatively absolute. Like people who have epilepsies, like I said, TMS have some risk of seizure. So epilepsy can be a relative absolute contraindication, especially for people who have active epilepsy and they're not controlled. But if somebody had very remote history of epilepsy and they have been well controlled for years, they are a good candidate for this. The relative contraindications for this treatment, it can be either pacemakers, or there's a history of significant head trauma or brain surgery, or recent stroke, or active substance use. So recent stroke, a lot of times people who have stroke, they develop this something called post stroke depression or post TBI depression, which is kind of pretty common. And there are studies that have been done, and actually it says that using TMS aid in help in stroke recovery. But again, the only problem is there's a little higher risk because it decreases the seizure threshold. And also people who have active substance use, they have to be basically sober for some time before they can get this treatment. They have to be abstinent. The only reason why is because, again, we don't know if the patient is not responding because of the treatment, or is if they're actively using substances. So that is why that's a relative contraindication. So like I said, even though it's a non-invasive technique, it has some, mild side effects, which are basically, because of lowering the seizure threshold. So, yes, I'm sorry. A second. All right. So for treatment-resistant depression and and PTSD, depressive symptoms, they likely improve, or they actually can go away after a few weeks of TMS treatment. So during the TMS treatment, the patient can continue their regular medications, or or therapy, just to prevent relapse. But sometimes patient can get off of medication, or they can actually go down on the dose of their medication they're taking. So if people have responded to TMS initially, if they have relapse, the chances are that they're going to respond it again to the treatment are very high. And like I said, it has also been used for the treatment of generalized anxiety disorder and bipolar depression. But again, in treatment of mania, it has mixed results, but I would not recommend if somebody's having a manic episode to get this treatment. Uh, and also, TMS is a safe and effective for stroke complication as well, and it accelerates their recovery. Um, TMS is also, being studied in multiple neurological disorders, and it's actually a lot of neurologists, they're actually using it in their practice, and to improve symptoms in Parkinson's disease, in tremors, in epilepsy, dysarthria, and aphasia as well. For Tourette's and OCD, like I said, for OCD, this is FDA approved, but this is also used for Tourette's. It's just that we use a low frequency TMS to control the hyperexcitability of the brain. And we basically target a different area of the brain in OCD, and which I'll go over in some time. And also, this is also used for smoking cessation. It's like I said, there are four conditions that are FDA approved: treatment-resistant depression, obsessive compulsive disorder, smoking cessation, and migraine. So we use high frequency. If somebody wants to get off of, want to stop smoking, this can be used as well. But again, there are medications for smoking cessation, and you should talk to your doctor about it if somebody is looking into stop smoking. So let's look at this is the PET scan of the brain of a depressed patient. So this is how it looks. So this is a patient with no depression, and this is a patient with depression. So when you look at this warmer color, right? So this is a normal looking brain. And the blue and green color you see here, this is an underactive brain. So in depression, if you look, there are multiple areas in the brain that are underactive. So what TMS does is, when you stimulate that area of the brain, this is actual functional MRI. When you do, so basically they looked at the functional MRI of the patient while administering a TMS, and how does that look like? So when you look at it, when you're doing the TMS, it's actually increasing the connection or connectivity between different areas of the brain, and also increasing the activity in the brain. So, like I told you before, there are up to 36 sessions of 19 minutes each for for 6 to 8 weeks, and it requires commitment. It requires regular visits. But again, this is during a short space of time, and it has long, lasting effects. But again, patient can resume normal activity following their treatment. Right after the treatment, they can go back to whatever they were doing before. And it can benefit, like, who can benefit from it? Like I said, the people who are diagnosed with depression or treatment-resistant depression, or patients who don't want to be on medications, or who want to go down on the dose of the medication, or they just want to basically support the process of recovery. They can basically qualify for TMS. So This is, I want to talk a little bit about the TMS, basically deep TMS in OCD. So FDA approved TMS for OCD in August of 2018. So it's been 7 years. But again, like I said, not a lot of people are using it, but this is FDA approved. And people or patients who are diagnosed with OCD, they need higher doses of medication. They need very high doses of medication. And I kind of feel that this can be a very good alternative to avoid taking the higher dose of medications, and also to fasten the recovery. So again, the protocol is going to be a little different. The way you administer the treatment is going to be a little different, and the way the area of the brain that is being stimulated in OCD treatment is going to be a little different. Like I said, it is the motor area and also the orbitofrontal cortex that is being stimulated. So in general, this is what I would say. So 1 in 2 people, they have complete resolution of their depression, and it can last up to a year, in many clinical studies. And two-thirds of the patients who have gone through TMS, they have reported clinically significant improvement that have lasted for a year. So even though this treatment is not being used that frequently, but I feel like this is a very good alternative, especially for people who are looking for something more or something different than the medications and therapy. So I think this is a very good alternative. And these are all my references. And I have a couple of clinics in White Plains and also in Briarcliff Manor. And if anybody has any questions or any concerns or anything, just please feel free to contact me. So this video session is going to be on the Chappaqua Library website. You can go over it if you want to review my lecture again, or if you want to reach out to me, please, you can just Google my name, or you can find my information on the website. I hope you guys have a wonderful night. I know, Joan, we are going to go open to questions now.
Right.
Okay.
And I'm just going to mention that if anyone has any questions, you could type them into the chat function, which you should find on your screen. You just type them in and then hit enter, and we will read them. We're not getting any questions. I guess you were very thorough. Thank you so much for coming, and thank you for this. This really, I was quite impressed with all this information. I didn't know anything about it at all.
Like I
So
said,
thank
it's
you
a
very
very
much.
new treatment. Not a lot of people know about it, and I thought this would be a very good platform to educate, our community people.
Okay.
All
Thank
right.
you all for coming.
All right.
And don't
Have a
forget
good
to go
night.
to the Chappaqua Library website, look at all the programs that we offer. Thank you.
All right. Great.
Bye-bye,
Have a
everyone.
good night, John. All right. Have a good night.